All right, let's talk about something we all deal with in the clinic. A new study just dropped in JAMA Oncology, and it's asking a really practical question. Can something as simple as a magnesium infusion help prevent one of the most serious complications of cisplatin? Let's break down the evidence and figure out what it means for our day-to-day practice. So here's the big question, right? We're talking about a major complication from a cornerstone chemotherapy drug. Could something as simple and frankly as cheap as an IV magnesium drip actually move the needle and protect our patients? That's exactly what this study set out to investigate. Okay, first things first, let's just quickly set the stage with the problem here, and it's a problem we all know well. Cisplatin-associated acute kidney injury, or CPAKI. And let's be clear, this is not some minor nuisance side effect. We're talking about a really significant clinical challenge that can have some pretty severe consequences for our patients. And this is the real kicker, isn't it? The downstream effect. This isn't just about the creatinine going up today. It's about whether or not that patient can even get their next cycle of potentially curative chemo. It has huge implications for their entire treatment course. So, how did the researchers go about tackling this question? Well, they went big. They decided to take a large-scale, real-world look at what's actually happening out there. So instead of a small, tightly controlled trial, they tapped into this absolutely massive data set. We're talking 5 major cancer centers over a 16-year span. The whole idea was to get a picture that's more generalizable, more reflective of what we see every day. And just look at the scale of this work. They started with this enormous pool of over 30,000 patients. Then they methodically filtered that down using specific criteria, leaving them with a really robust final group of almost 14,000 patients for the actual analysis. That's a huge cohort. Okay, so after all that work, what did they actually find? Let's get to the juicy part, the results. All right, let's look at the raw numbers for their primary outcome. And remember, that was a combo of moderate to severe kidney injury or death within 14 days. And right off the bat, you see a pretty stark difference. Look at that, 2.7% in the magnesium group versus 5.3% in the no magnesium group. That's almost half. But, raw numbers can be misleading, right? The two groups weren't perfect mirror images of each other to begin with. So the researchers did their due diligence. They ran the stats, adjusting for all the things you'd expect, age, other health problems, the cisplatin dose. And after all that number crunching, they landed on this adjusted odds ratio. So what does 0.80 actually mean for us in the clinic? Well, it translates to this. After you account for all those other factors, getting prophylactic IV magnesium was associated with a 20% lower odds of developing that kidney injury or dying. That is a clinically meaningful signal. But they didn't stop there. They wanted to know, does this benefit everyone equally? Or are there specific subgroups who really seem to get the most out of this intervention? And this is where it gets really interesting. When they looked at the subgroups, some clear patterns started to emerge. The benefits seemed to be stronger in younger patients, those under 65, and in women. And a little bit counterintuitively, it also seemed to work best in patients who had better kidney function and higher magnesium levels to start with. That's definitely something to think about when we consider who might be the best candidate for this. Okay, so the results look pretty promising. But as always, we have to put on our critical thinking hats. No study is perfect, so let's talk about the strengths and, just as importantly, the limitations here. On the plus side, this study has a lot going for it. First, it's huge. A large multi-center cohort means the results are much more likely to apply to our own diverse patient populations. They also did a really thorough job trying to adjust for confounders, and the findings held up across different ways of slicing the data, which is always reassuring. But, and this is a big but, we have to remember what kind of study this is. It's an observational study. It is not a randomized clinical trial. That means it shows a really strong association, but it can't prove cause and effect. There's always the chance that some unmeasured factor, like, say, differences in how centers hydrate their patients, could be the real reason for the difference. It's correlation, not causation. That is the key limitation to keep in mind. So where does all of this leave us? What's the clinical bottom line? What do we do with this information when we walk into the clinic tomorrow morning? Well, the authors themselves are pretty clear about the next step. They state it right in the paper. We need a randomized clinical trial to really confirm these findings. And they're absolutely right. That's the gold standard, the only way to know for sure. But that puts us in a really interesting spot, doesn't it? We're waiting for that gold standard RCT, which could take years. In the meantime, we have this very strong signal from a huge real-world study for an intervention that is incredibly cheap, super safe, and easy to give. So the question for all of us is this evidence good enough to change your practice now? Or do you wait? That's the debate this paper really sparks.